Thank you, Steve, and thank you for joining us this morning. My name is Vanessa Heasler. I'm a Professor of Nursing and Healthcare Equity at the University of Salford.
And I am Christina Vasilika. I'm an Associate Professor in Digital Health and the Head of Digital Education at the University of Salford.
This morning we're going to talk a bit about digital illiteracy and poverty. So we want to start by really looking at the importance of digital healthcare. It really has the potential to improve health outcomes for all. We know from the Strategic Development Goals by the United Nations that good health and well-being, but also reducing inequalities, is a fundamental part of our professional practice. But in order for this to occur, we've got to make sure that the technology that we use has three main components. The first, that it's safe to use, actually that people can access it, they can access services. We've got to make sure that it's fit for purpose, and that's about engaging with healthcare professionals and practitioners to ensure that whatever we're developing, they're able to use for the benefit of high quality patient care. And then the third is it's universally accessible. And that's really the point that we want to explore with you this morning. And I think a key aspect of that is ensuring that the professionals, so the nurses and midwives that are using it, both are capable and confident to use the technology that we're using. So if we think about what is digital technology, it encompasses really data that brings together both health and digital in the same field. And we know that there's been a massive growth in this over the last couple of decades, most notably a huge shift following the COVID pandemic. And that really forced us to work in different ways as part of the national lockdown strategies. So there are two main approaches within the digital technology. So we've got the direct approaches, that's the sort of applications that people use. It might be wearable devices to monitor things like blood pressure or to manage diabetes. But also we've got these indirect approaches, and that really enables us to think about the data we collect, how we utilise that data to really challenge and promote actually more inclusive healthcare practice as we move forward. So there are a plethora of policies, and we've mentioned some of them here, and some of them are global policies, some of them are national policies. If you've not had a chance to look at some of the policies, both from the World Health Organization, but also the European region, we really think it's worth you doing that, because that's driving the international agenda with regards to digital healthcare. And then we've also listed some of our national policies here. One of them to note is that actually we are waiting for the Phillips Ives review to come out, and that should be with us shortly. And that really is going to help move the direction forward. What I want to do is to spend a bit of time looking at poverty. And really, poverty is the single largest determinant of health. Quite frankly, poorer people have shorter lives, and actually they have greater health and well-being challenges. If we think about that in terms of some of the social outcomes, actually poverty has a negative impact on your educational attainment, your family functioning, your exposure to abuse and crime, and this is really well documented. And so if we think about poverty, we know, for example, in the UK, someone living in a deprived area of England is more likely to die 8.5 years younger than someone who lives in a more affluent area. But they will also experience more ill health, reduced well-being compared to their wealthier counterparts. In addition to poverty, we know that there are other factors that also influence health and equity, and that includes things like sex, ethnicity, disability, etc. But we have to recognise that people also have these intersecting positions that compound their experiences. And we've got to recognise that within the cost of living crisis that we're having currently. So I was watching on the news last week, and they were saying that every 8 minutes a family becomes homeless and moves into temporary accommodation like bed and breakfast. And we know that there is a massive growth in the use of food banks within the UK because of things like fuel and bills that are increasing. And so this is a really big issue that we are facing currently. What you see at the bottom are a couple of reports from Michael Marmot. So in 2010, Marmot did a really massive sort of seminal piece of work that identified and argued this social gradient of health. And that really is essentially saying the lower your social position in society, then the worse your health. The higher your social position, the better your health. And so he really argued in this first major report that really social policy and actions really need to focus on addressing this social gradient of health, really saying that there needs to be a multi-agency approach. A subsequent report 10 years later, presented and published in 2020, really examined the progress that we'd made in light of this social gradient. And then sadly, rather than identifying improvements in health inequities, he found that the opposite was true. There was a widening of health inequities within England, most notably for women. Since then, we've had the COVID-19 pandemic. We know that that's had a significant negative impact on the most disadvantaged groups in society, and we're still feeling these repercussions. So if we look at well-being between high and low incomes, it's increased by 50%. But also it's led to a distrust in governments and others, and that threatens people's sense of belonging and cohesion within society. And that compounds those pre-existing social inequities. And this really has a direct link to health. So we know that socially excluded groups, men are more than 8 times more likely to die. Women are 12 times more likely to die. So if we think about social exclusion and poverty, we know that social exclusion is often the cause of poverty, but also the links between digital exclusion, social exclusion, and poverty are inextricably interlinked. And what you can see in the diagram around the outside is a range of factors that influence people's likelihood towards becoming socially excluded. And that's things like age, gender, race, ethnicity, disability, migration, to name but a few. So we know that because of this growth in health and digital health, that this has really led us to consider actually the impact that digitalisation has across the life course. So much so that Kit Bush and colleagues really argued that this digital transformation has to be considered as a new determinant of health. They And this is due to the significant impact that it has across the life course. And there are main contributors to digital exclusion, and we've included Q codes so you can have a little bit more look at that. But really, these 3 main areas are around social exclusion, that's low income, poverty, which leads to avoidance of technology, lack of motivation and commitment, or disability, a digital exclusion, and that's linked to poverty too. So a lack of either the actual hardware devices themselves or an inability to afford the internet services. And then third is around that accessibility, and that's around the connectivity issues. And we know that there are still major challenges between urban and rural areas. So what I'm going to do now is I'm going to pass you over to Christina, who's going to look at some ways in which she successfully managed to address some of these challenges that people face.
Thank you, Vanessa. In the next few slides, I will explore in brief various concepts associated with digital transformation and practical implications linked with digital inclusion. Digital transformations refers to the profound and comprehensive integration of digital technologies, which leads to fundamental changes within an organization. In the process of digital transformation, it is vital to ask the question, is the organization ready to embark on this journey? And to answer it, it is important to assess the infrastructure, for example, Wi-Fi and the devices, and staff perceptions of providing care in a digital age, their skills and capabilities, confidence, and the gaps that exist in training. Before embarking on this journey, also assessing patients' readiness, their digital skills, and access to devices remains crucial for providing patient-centered care, improving engagement, and access to healthcare services. Using the knowledge from the readiness exercise, you are then able to propose a solution that addresses people's needs and reduces inequality. Finally, a comprehensive evaluation throughout the digital transformation journey is essential for making informed decisions, optimizing processes, and ensuring that it brings value to all stakeholders involved in the process. In this slide, we've captured some of the key challenges associated with digital literacy and proposed some solutions. There is also a QR code for you to scan and share your personal experiences and views with us. So the first challenge is that people are not always aware on how to access and utilize the digital. In this scenario, it is important to consider assessment of need, digital readiness, the digital readiness exercise I've mentioned before, provide training and onboarding solutions, establish support networks, for example, digital champions and peer mentor, and importantly, go to places that people inhabit, like online social media communities or offline libraries. The second is digital technologies' central role in healthcare often goes unrecognized or not seen as central to nursing practice. Therefore, providing training, explaining concepts and application to practice, allowing space to look at the future, and provide feedback to close the learning loop are some of the key solutions. The third challenge is lack of access, and especially for those in more deprived areas. So, according to latest statistics, in 2021, 88% of all UK adults had a smartphone. When this is broken down by age, 96% of those aged 16 to 24 owned a smartphone device, compared to only 70% aged 55 and above. In this instance, we have to explore the context, profile the end user, and find solutions which often have to be more creative, for example, partnering with local charities. Literacy is another challenge. In England, almost 70% of the adults can be described as having very poor literacy skills. This, coupled with medical jargon, adds an extra layer of complexity for people to digest information. Therefore, we must use simple, plain language. And I remember in one of the studies that I done in the past, one of the patients referred to as using language for dummies. And finally, we must also consider different learning needs and disabilities to create a more engaging and inclusive environment. Okay. In the next few slides, I'll briefly showcase some of the concepts that I've explained above and how it links with practice. The first example is from award-winning Kidney Information Network, which connects more than 1,000 patients in northwest of England, and the network was initially established in 2013. KIN builds on the principles of attracting people in the spaces they naturally inhabit to offer an inclusive digital, social, and health space. KIN uses micro-communities set up as Facebook group, all connected via a KINet hub, and service different geographical locations. Cross-platforms are used as part of KIN to expand the network reach and provide information in multiple styles and formats. As part of KIN, we consider co-production. So the initial stage of the project involved co-developing the network and the information with input from patients, carers, and clinicians. This involved three stages: consultations to explore platforms, initial feedback on the intervention, and then final testing. As part of this, inclusivity was also built into the testing stage, as patients who are not regular internet users were also recruited into the study. They received an iPad and training. For some, as the patients indicated, the iPad then became like a lifeline. The platform was moderated with input from patients and an advisory group. Okay. So patients who engaged with KIN reported positive health and social outcomes. The information shared on the hub addressed their information need. and we are now in the process of establishing a national kin. Next, I'll bring an example of a digital readiness study that we are currently working on with a local trust. As part of the study, we thought and designed a process through interviews and a survey about how to assess digital readiness, and we now have the tools to be able to apply this elsewhere. In the next slides, I'll intro an example of a learning solution, which is the University of Salford Digital Skills Passport, or DISPAS, which is a novel solution to equip all our pre-reg nursing students with digital capabilities required to thrive in today's digital world. This pass has been designed to meet the NMC Standard Framework for Nursing and Midwifery, NMC 2018, and the Health Education England Digital Capability Framework 2018. It encompasses specific themes like digital professionalism, harnessing the power of digital technology in healthcare, and the digital future. Students learn about digital profiles, communication, networking in a digital age, cyber safety, but also the implication of digital technology like mHealth, extended reality, AI, data, ethics, and digital innovation. Examples of activities include reviewing their digital footprint, identifying challenges in practice, and proposing digital solutions, but also reviewing existing case studies. The preliminary evidence points toward this path impacting on students' digital confidence, and we noted a shift in how technology is perceived by student nurses and a desire to continuous personal development. I'll now hand on to Vanessa for conclusions.
Thanks, Christina. I'll just wait for the conclusion slide to come up. So hopefully what you've seen during the short time that we've had together this morning is that poverty is a real issue within the UK. People living in poverty have greater challenges around accessing digital healthcare. We also know that there is a health divide within the UK. And if we really want to use digitalisation to promote safe, effective care for all, we've got to ensure that nobody is left behind. And so part of that is really thinking about these key points that we want to raise at the end. And that's firstly, if you're involved in a development of a digital service, a digital aspect to your service, you've got to examine it critically from an inclusivity point of view. Does it enable access for all? If it doesn't, then actually all you're going to be doing is perpetuating the health divide and reducing our ability to meet the UN Sustainable Development Goals. You also have to consider your workforce. You've got to consider the service in which you work, and that's a degree to which you're ready for a digital innovation. Your workforce is not a homogenous group. They're going to be made up of lots of different practitioners, and some of those may have particular needs. They may have disabilities. They may have different levels of digital literacy, and that's got to be considered as part of the readiness before you go ahead and develop and deliver your service. We argue that you must involve users, and those users include both the patients that are going to be using your service, but also the staff that are going to be using your service. Often our default is our own digital capabilities, and we assume that everybody's like us. But actually talking to other people, engaging with them, will enable you to see some of the challenges that actually people may face. And a classic example of that is for somebody that's homeless, we know that quite a few people that are homeless will have lost their teeth. And if you lose your teeth, it changes your pronunciation. And so for those individuals, actually chat boxes don't work particularly well because it doesn't recognise the sound of their voice. Now, you'd never know that unless you engage with somebody who was homeless, for example. And the last thing is about engaging much more from a transdisciplinary perspective. And that's about engaging with third sector organisations, wider services, for example, such as libraries, that really can be a lifeline around enabling people that can't afford technology to be able to access things like the internet. We thank you for your time this morning, and we look really forward to our discussion in our question and answer session. Thank you.